Hey, good afternoon, everyone. We'll get started. On behalf of the Education and Professional Development Committee, I would like to welcome you to today's webinar entitled Pharmacy Advocacy. If not you, who? I'm thrilled to introduce two individuals who are not only my great friends, but who have also really helped spearhead the Royal County's advocacy effort. First, I'm going to introduce Dr. Samantha Payon. Dr. Payon obtained her doctorate of pharmacy degree from Ernest Mario School of Pharmacy at Rutgers University. She then went on to complete a PGY1 residency at the Brooklyn Hospital Center, and then a PGY2 pharmacotherapy residency at North Shore University Hospital. Dr. Payon currently serves as the ambulatory care CDTM oncology pharmacist at Staten Island University Hospital, Northwell Health. As if that wasn't enough, she's also currently secretary and grassroots co-chair of Royal Counties. Next, we have Dr. Rachel Quinn. Dr. Quinn obtained her doctorate of pharmacy degree at Wilkes University Nesbitt School of Pharmacy in 2016. She then went on to complete a PGY1 residency at the VA Hudson Valley Healthcare System, followed by a PGY2 residency at the Brooklyn Hospital Center, specializing in ambulatory care. Dr. Quinn currently practices as a CDTM clinical ambulatory care pharmacist at New York Health and Hospital Metropolitan, where she manages chronic diseases under a collaborative practice agreement. She is also currently president-elect of Royal Counties and very highly active in the Royal's Grassroots Advocacy Committee. So before we get started, a few quick points. For those who have any type of technological issues during the presentation, please use the chat option to communicate with the office. Every effort will be made to assist you in resolution. Secondly, for those who have questions during the presentations that are directed to the speakers, please use the question box or the chat option on Zoom. And lastly, the CE code will be provided at the end of the program. So without further ado, I'm going to turn this over to Drs. Payon and Quinn to begin the program.
Thank you, Dr. Gerber, for the introduction. Dr. Quinn and I are excited to be here today to present Pharmacy Advocacy. If not you, who? Dr. Quinn and I have nothing to disclose. Our objectives for pharmacists are located on this slide. For the sake of time, I won't read through these. Additionally, here are the objectives for pharmacy technicians here for your reference. Many of you listening today may be thinking, what is advocacy and how does it relate to my profession? Advocacy can be defined as an activity by an individual or group to plead a case, support a cause, or to recommend a course of action. The reason why we're here today is to specifically talk about advocacy as it relates to the pharmacy profession. Many of you remember the oath of a pharmacist that you vowed when graduating pharmacy schooling. That quote is here at the bottom of the slide. It reads, "I will embrace and advocate changes that improve patient care." What we do know is that pharmacists have a responsibility to advocate on behalf of their patients for the right to safe and effective medication. However, pharmacists must also advocate on behalf of the profession through legislative efforts. This involves knowing and understanding the legislative issues that are affecting public health and pharmacy. We hope that more pharmacists become more active in legislative efforts of pharmacy organizations such as NYSCHP, through personal contact with local legislators, which is something that Dr. Quinn and I hope that we can help you with today. Because at the end of the day, how can we hope for policy change if those making those decisions aren't fully aware of the scope of our practice or our capabilities? The goal is to educate these unconventional students or our legislators in order for our profession to have a voice in politics. Let's start off with an assessment question that will lead us into our first topic, the New York State government. What is the role of the New York State legislative branch? Select all that apply. Negotiate the budget, raise or lower taxes and fees, appoint and remove non-elected state officials, pass bills, veto legislative bills. And you can go ahead and put the answers into the chat. Great, thank you for that. So for our answer, it looks like most of you answered this correctly. The New York State legislative branch is responsible for negotiating the budget, raising and lowering taxes, and most importantly, for the purpose of this presentation, passing bills. Reviewing the New York State government structure will help us have a more rooted understanding of where the bills we'll talk about today stand. The New York State government is divided into 3 branches: the executive branch, legislative branch, and judicial branch. Today, we're going to focus on the legislative branch. New York State is divided into 62 counties. New York State has a legislature consisting of a lower chamber, which is the New York State Assembly, and the upper chamber, the New York State Senate. They're responsible for negotiating the budget, raising or lowering taxes and fees, and passing bills. Each one of you living in New York State have 1 assembly member and 1 senator, and you are their constituent. Informing a legislator at a visit or through email that you are a constituent is extremely important, as you are a voting member that has the power to appoint or select in future elections. Now that we know that the legislative branch passes bills, how does a bill become law in New York State? First, there has to be some sort of idea. These ideas come from many sources. People tell their stories through legislative meetings, such as a grassroots advocacy committee. They could, perhaps a senator or an assembly member can have an idea. A state official may propose a change. Then there's a drafting process in which the bill is created into a formal language. Once the bill is introduced by legislators by the chamber's leadership, so that's either the Assembly Speaker or the Senate Majority Leader, this bill is referred to their standing committee. Standing committee are groups of legislators that regularly meet to consider legislation on certain topics. These committees meet and they review, discuss, revise, and ultimately either approve or disapprove the bill. If the bill is approved, the bill then could be moved to the floor for final decision. If the bill is approved in both the Assembly and Senate without any amendments, the bill can then go to the governor for final signature. On the previous slide, we discussed how bills are assigned a specific standing committee before they're introduced to the floor. As a reference, here are a list of the 3 bills that we're going to be discussing today and their standing committee status. Meeting with the legislator who is a member of one of these committees may be extremely helpful in gaining our bill's support. But for now, I'll pass over to Dr. Rachel Quinn, who will talk about Advocacy Week and start to introduce the bills we're advocating for.
Perfect, Dr. Payon, thank you for the wonderful introduction. And next we will review Advocacy Week. Next slide. Pharmacy Advocacy Week is 1 week dedicated for NYSCHP members to meet with their local legislators to promote bills relevant to health system pharmacy. We will discuss the 3 bills on the upcoming slide. This year, Advocacy Week will take place from February 14th to February 18th. Meetings take place either in person or virtually via platforms such as WebEx or Zoom. However, due to the current pandemic, visits this year will take place virtually. We also want to give a special thanks to Amanda Mogul, who is the Advocacy Week chair, because without her, none of this would be possible. These are the 3 bills we are lobbying for with our Assembly and Senate sponsors. The 3 bills are the Collaborative Drug Therapy Management Bill, also known as the CDTM Bill, the Clinical Laboratory Improvement Amendments Bill, also known as CLIA, and the White and Brown Bagging Bill. For the CDTM and CLIA bill, we will ask legislators for co-sponsorship, as these bills currently have an Assembly and Senate sponsor. And for the White and Brown Bagging Bill, we will ask for co-sponsorship for senators and a sponsor for Assembly members. Next slide. There will be prep calls before Advocacy Week. The legislative prep calls will start on February 8th and be held until February 15th. All participants should attend 1 prep call before Advocacy Week, and the links will be put in the chat. We also want to give a special thanks to Michael Malazzo, Andrew Kaplan, and Sean Flynn for running these prep calls. Next slide. Advocacy Week 2021 took place from February 8th through 12th. During this time, NYSCHP members focused on promoting 2 bills, which were the CDTM and immunization bill. There were a total of 55 visits conducted with participation from 120 members. Dr. Payon and myself are proud Royal Counties members and are proud to say that Royals completed 10 of the 55 visits. Next slide. Here are photos that we're taking during Advocacy Week 2021. Always remember to ask your senator and assembly member if you can take a photo and if you can promote it on social media. Next slide. Advocacy does work and your effort does not go unnoticed. One huge success from Advocacy Week 2021 is that the immunization bill passed in Senate and Assembly and was signed by the Governor of New York. This allows pharmacists to vaccinate all CDC recommended vaccines for adults and remove the sunset. Of note, a sunset is a statute that automatically terminates the law at the end of a specified time period unless it is reauthorized by legislation. Next slide. Next, we will discuss the Collaborative Drug Therapy Management Bill. The bill numbers are below for your reference. Next slide. But before we get started, we have one pre-assessment question. The question is, pharmacists can perform collaborative drug therapy management, or CDTM, under the direct supervision of which medical professional? Select all that apply. And if you can, please write your answers in the chat box. Okay, it seems like most people are getting the answer correct, which you could go to the next slide, which is medical doctors or doctors of osteopathy. Next slide, please. Collaborative drug therapy management, or CDTM, is a written protocol between a physician and a pharmacist that allows the pharmacist to manage medication regimens of chronic diseases, including diabetes, hypertension, asthma, heart failure, etc., in a hospital or health system setting. Washington and California were the first states to allow CDTM, and CDTM was passed in New York State in September of 2011 as a pilot project. Therefore, pharmacists have been practicing CDTM for over 10 years in New York State. Next question. Next slide. The most common question I get asked is, what do you do as a CDTM pharmacist? Under my scope, I can order lab tests related to medication therapy. For example, if I have a diabetic patient on metformin or an SGLT2 inhibitor, I can order blood work to evaluate their eGFR or kidney function. I can also collect or review patient history. For example, if I'm thinking of starting my patient on an SGLT2 inhibitor, I may want to review their past medical history or history of recurrent UTIs. Next, I can order or check vital signs. If I'm in a heart failure clinic, I may want to review the patient's heart rate or blood pressure before adjusting medications such as beta blockers or ACE inhibitors. And finally, we can adjust medication therapy, including dose, route, and frequency. Of note, all this must be stated in the institution's protocol. However, this protocol can be as specific or lenient as the institution would like. Next slide. Next, we're going to have another pre-assessment question. The question is that patients are required to have written patient consent to be managed by a pharmacist under a CDTM agreement. True or false? Okay, it seems like everyone is getting this answer correct as well. The answer is true. Here's an example of written patient consent. When I see a patient for the first time, I introduce myself as a pharmacist that works with their primary care doctor in order to control their chronic disease state. For me, this is mainly diabetes. I then proceed to explain how my role may differ from a traditional pharmacist role. For example, I can adjust medications, order labs, etc. I also state that all changes will be documented in their health record and that their primary care provider will be made aware. I also explain to patients that they can choose not to participate in this agreement and that they can withdraw their consent at any point in time. The consent forms are then scanned into the patient's medical record after the visit. Of note, if a patient is unable to sign, a legally authorized representative may sign the consent form on their behalf. Now, some written consents require a witness. The witness is a staff member who is not the patient's physician or authorized healthcare provider. And typically the witness is a patient care assistant or a medical assistant. Next slide. Unfortunately, there are many restrictions to CDTM. The first restriction is that CDTM can only occur in Article 28 facilities. Facilities regulated under Article 28 include any diagnostic center, treatment center, or hospital-based outpatient departments, including outpatient clinics. Residential healthcare facilities, rehab centers, and nursing homes are excluded with the exception of nursing homes with an on-site pharmacy staffed by a licensed pharmacist. Additionally, both pharmacists and physicians must be employees of the same facility. Next is that pharmacists can only enter into a CDTM agreement with a medical doctor or doctor of osteopathy and not a mid-level practitioner such as a nurse practitioner. Due to this limitation, not all patients can be managed by a pharmacist under a CDTM agreement. Next is that patients currently have to provide written consent to be seen by a pharmacist. Since the pandemic, this can be signed electronically. However, this can pose technical challenges for our older patients. And currently there is a sunset on CDTM in July of 2022. And this sunset occurs every 2 years. As a reminder, a sunset is a statute that automatically terminates a law at the end of a specified time period unless it is reauthorized by legislation. This sunset creates an unnecessary burden for physicians and pharmacists to gain key leadership support to create and grow practices. Next slide. Although there are numerous restrictions to the CDTM bill, these are the specific objectives of the bill. First, we want to remove the sunset and make the law permanent. And second, we want to add nurse practitioners as providers of service. Next slide. There are numerous benefits to the CDTM bill, and here are just a couple of examples. First is that pharmacists can enhance patient care through optimized drug therapy management. For example, if I'm managing a patient's diabetes and they also have clinical ASCVD, I can prescribe an agent that has been shown to reduce major adverse cardiovascular events. The next is increased access to care. Depending on availability, some patients wait several months for a doctor's appointment. Pharmacists can see patients on a more regular basis in order to control chronic disease states within their scope of practice. For example, I can see patients on a weekly basis in order to titrate their insulin. CDTM also decreases hospitalizations by controlling chronic disease states and reduces costs through optimal use of medications. Another thing to note is that by controlling chronic disease states, the physicians will have more time for management of more complex patients. Next slide. Oppositions to the CDTM bill revolve around nurse practitioners being added as providers of service. Many medical societies suggest that nurse practitioners do not have sufficient pharmacology background to successfully work with pharmacists, and that physician-pharmacist CDTM protocols are too premature to add nurse practitioners. But we have to remember that pharmacists are the drug experts. Therefore, we can help fill any gaps in knowledge. And in addition, these protocols have been around for over 10 years and are well established. Next slide. This slide shows how CDTM differs in New York State versus other states. As of 2020, pharmacists were legally authorized to participate in CDTM in 49 out of the 50 states and the District of Columbia. Delaware is currently the only state without CDTM legislation. And as of 2020, 20 states required certain pharmacist qualifications to participate in CDTM. This could include anything from extra continuing education, board certification, or residency training. And on the next slide, we will review the criteria in New York State to becoming a CDTM pharmacist. To become a CDTM pharmacist, first you need to apply at the New York State Department of Education, and the link is on the slide. To become a CDTM pharmacist, you must meet criteria 1 and 2, and either criteria 3 or 4. Criteria 1 is that you must be licensed and currently registered to practice as a pharmacist in New York State. You must also be licensed to practice pharmacy for a minimum duration of 2 years if you have a doctorate of pharmacy or a master's of science in clinical pharmacy degree, which is highlighted in black, or 3 years if you have a bachelor's in science of pharmacy, which is highlighted in blue. For criteria 2, you must have a minimum of 1 year of clinical experience as a licensed pharmacist. And a pharmacy residency can be used to satisfy this requirement. And we will review criteria 2 in more detail on the next slide. Oh, go back one slide, sorry. Criteria 3 is board certification by an accreditation body approved by the department. For example, I'm a board certified ambulatory care pharmacist, and Dr. Payon is a board certified pharmacotherapy specialist. And finally, criteria 4 is completion of an accredited or accreditation pending residency program. Of note, a pharmacy residency cannot be used to satisfy both criteria 2 and 4. However, a PGY1 can be used to satisfy criteria 4, and a PGY2 can be used to satisfy criteria 2. Next slide. For criteria 2, pharmacists must provide detailed clinical experiences within 3 years prior to submission. And this includes detailing all clinical activities performed, percentage of work hours spent conducting these activities, patient populations managed, and other pertinent direct care activities. Please remember that inpatient experience does count and that CDTM is not just for outpatient pharmacists. And finally, your clinical experiences and completed application both need to be notarized before being sent to the state board. Next slide, thank you. A CDTM pharmacist can be identified by locating a C after the pharmacist license number. As you can see, this pharmacist has both an I and a C after their license, meaning that they're both immunization and CDTM certified. Next slide. CDTM can be found across a large variety of settings, including both inpatient and outpatient. And these are examples of CDTM clinics that are practiced both where Dr. Payon and I work. I work in a primary care/medicine clinic, which covers patients with diabetes, hypertension, hyperlipidemia, smoking cessation, and anticoagulation. New York City Health and Hospitals also has virology clinics, which includes patients with HIV and hepatitis C, as well as behavioral health clinics. Dr. Payon works in an oncology and hematology clinic, and we will learn more about her practice during the white and brown bagging bill. Next slide. The CDTM bill can be very complex and hard for local legislators to understand. Therefore, at Royal County Grassroots meeting, we'd like to share examples. So do any audience members have personal experiences practicing under a CDTM agreement that they would like to discuss? If so, feel free to unmute yourself or type it into the chat box.
I can discuss my experience with CDTM. So currently I'm a CDTM pharmacist at New York Health and Hospital, Coney Island. I help manage patients with diabetes. So patients are referred to me or my co-CDTM. At that point, we can order labs, change their medications, adjust it accordingly. I have patients who I see weekly to do insulin adjustments or adjust certain medications based on their CGM devices. So really a broad variety of things that I could do with my patients because of CDTM.
Perfect. Thank you, Dr. Gerber, for sharing your experiences. For the sake of time, we will move on to our next bill, which is the Clinical Laboratory Improvement Amendments Bill, which is also known as CLIA. And the bill numbers are below for your reference. During the pandemic, pharmacists proved to be valuable members of the healthcare team, not only with administering COVID vaccines, but also administering COVID tests under the Public Readiness and Emergency Preparedness Act, which was known as PrEP. This greatly impacted our community in the fight against COVID-19. However, once the state of emergency ends, the authorization ends. CLIA waive tests are simple and non-invasive tests that can screen at-risk patients for certain health conditions, enabling timely detection and referral for further medical care. Examples of this test include point-of-care A1C testing, HIV testing, and influenza testing. However, a full list can be found at cms.gov, which is the Center for Medicare and Medicaid Services. Next slide. So what will this bill do? This bill would add pharmacists to a list of licensed healthcare professionals who are qualified to perform clinical laboratory tests that do not involve invasive modality. It directs the Commissioner of Health to establish a list of CLIA waived tests that pharmacists may be able to perform. And finally, it would strengthen the physician-pharmacist collaboration, by establishing communication protocols for test results. Next slide. There are many benefits to CLIA. First, it expands access to standard and basic clinical tests. Next, it avoids patients needing to seek higher levels of services, such as the emergency room and urgent care. It can also screen and improve chronic disease state monitoring, such as point-of-care A1C testing for patients with diabetes or prediabetes. It can also expedite treatment. And finally, it advances public health goals, such as stopping the spread of viral disease, such as COVID-19 or influenza. Next slide. For oppositions to the bill, the Medical Society of the State of New York, also known as NYSCHP, has stated that this bill would not provide continuum of care. However, one thing to keep in mind is that we are trying to improve access to care. By having community pharmacies perform rapid tests for COVID-19, we were able to alleviate lines for urgent cares and the emergency department. Another example would be prevention screenings in the community setting. As an API student, I did many blood pressure screenings on my community API rotation. Imagine if pharmacists were also able to complete point-of-care A1C screenings. If an A1C fell into a pre-diabetic range, we could provide education. And if an A1C fell into a diabetic range, we could encourage the patient to schedule a follow-up appointment with their PCP in order to avoid long-term complications of diabetes. Next, I will turn the slides back over to Dr. Paone to discuss the white and brown bagging bill.
Thank you, Dr. Quinn, for reviewing the first two bills. Let's now discuss the white and brown bagging bill. The bill currently has a Senate sponsor, and we are expecting the bill to be introduced to the Assembly soon, so hopefully we'll have an Assembly sponsor. To start, when I mention the term bagging, what this means is it indicates different methodologies of getting a physical package of drugs to a care setting, whether that's a physician's office or a health system, in order to be administered to a patient. Let's start with reviewing the more traditional model, or the health system hospital model. In a health system or hospital model, many of you may be familiar, a physician will enter an order or a patient's diagnosis and the treatment plan into the patient's electronic medical record. The health system will then receive the medication, and the system's pharmacy will store and prepare the medication until the day of the patient's infusion from their own inventory. This model is beneficial because it does a couple of things. It considers changes in the patient's clinical status that may require a dose modification or a medication change. The electronic health system also assures that important safety checks were put into place from start to finish. What's beginning to happen is that health insurance plans are implementing policies prohibiting healthcare professionals and providers from handling certain drugs. And they're requiring designated third-party pharmacies or specialty pharmacies to dispense these drugs for administration by clinicians. Ensure mandates requiring patients to have their therapies via white or brown bagging, and we'll define those in the next slide, are becoming increasingly common. For example, oncologists treating patients who insurers require these methods or methodologies have identified problematic issues, and these include concerns about patient safety, proper care coordination, potential delays in treatment, and even drug waste. And in terms of payment, I want you all to keep in mind that the medication in these methodologies is paid through the pharmacy benefit, not the medical benefit as we've seen with the more traditional model. White and brown bag methodologies are part of the specialty drug distribution process. Let's start with white bagging. And this is the red dotted line at the top. So this is where a specific medication is brought from a pharmacy to a physician's office or healthcare system in order to be administered to a patient. With brown bagging, or the blue dotted line at the bottom, there is the dispensing of a medication from a pharmacy to a patient who then has to transport that medication to the physician's office or healthcare system in order for that medication to be administered. As you can see, there are some consequences of these methodologies, and you can probably start thinking of them as I discuss how they work. But just to review, white bagging, the distribution of a patient-specific medication from a pharmacy to a physician's office for that to be administered to a patient. Notice here there's no middleman. The patient is not bringing the medication from one place to another or from a pharmacy to the office to be administered. But there are some consequences. The first one is medication waste. A lot of you who work with specialty drugs know that patients oftentimes require therapy modification due to lab results taken the day of, sometimes the day before, to see if they even qualify for treatment. A change in the dosage or strength, or even a change of therapeutic class altogether, is something that's relatively common. And if there is a dose modification or medication change, unfortunately, this medication can't be used for a different patient because it's that patient's own medication. And this can be considered insurance fraud if it is. Secondly, we worry about delays in care. Those who also work with specialty drugs know that the reimbursement and approval process is oftentimes difficult, as sometimes these specialty pharmacies don't have access to the electronic medical record. And lastly, we have to worry about the burden on the healthcare system. Physicians are now burdened with this unpaid expense of safeguarding and storing these patients' home medications until they're administered to the patient. And these medications, as I said earlier, can't be used for a different patient, so they have to be stored away from the office's own inventory. These medications are patient-specific, require special handling. This can pose safety, operational, and unexpected financial burdens for the healthcare system. Similarly, when we think about brown bagging, here, just to review, this is the practice of where patients picking up their drugs through their pharmacy benefit, then transporting that drug to the physician's office or hospital in order to have that administered. Many of these consequences are very similar to white bagging. For example, the first one, medication waste. In lieu of changes in lab values or even disease state progression, changes may occur, and these medications can't be used for another patient if that does happen. We also have to think about, again, these medications can't be used for another patient because it would be considered insurance fraud. Similarly to white bagging, we see that delay in care, the lack of access to the electronic medical record and patient information can really delay the medication getting to the patient. We also have to worry about delays in shipment as well and prior authorizations. Third, we worry about, with brown bagging, patient inconvenience. Specialty drugs, for example, require strict handling and storage instructions that patients may not be capable of doing. For example, temperature control can oftentimes be difficult in these situations, especially if a patient has to travel to go to their healthcare setting. This drug is being passed through multiple hands, which is, again, the medication could arrive late. And lastly, which I think is probably the most important here, is compromised medication integrity. The physician may be unable to determine whether or not the drug has been compromised during the transit. If the medications aren't properly handled, their potency or efficacy is questionable. Now that we've defined white and brown bagging and discussed their consequences, let's move into our specific bill objectives. The bill that we're advocating for completely prohibits brown bagging. The bill allows white bagging with some stipulations. Insurers must have an agreement with the provider that is responsible for receiving, administering the medication that includes specified notice, quality assurance, and safety provisions for patients. Also, another big one, which when we spoke about the consequences, this bill prohibits white bagging for sterile compounding drugs or patient-specific medications that require dose adjustments based on a lab results the day of or the day before a visit. As you can see, the bill protects patients by preventing unnecessary delays, confusion in treatment, which can increase patient risk and adversely affect patient outcomes. The only real benefit seen with these methodologies is that white and brown bagging may reduce physician costs because they're not purchasing these expensive medications. Keeping in mind, when we spoke about white bagging, however, now the health system has to spend money on equipment, staffing to help store these medications away from their physical inventory. Now that we've reviewed our bills for our legislative visits, let's discuss how to locate our legislators. On this slide, we've put the links to locate your senator and assembly member. Using these links provided, you can input your work and your home address to determine who your senator and assembly member are. Once located, you can email them directly from their website or send them a separate email. The next question, which I promise is not a trick question, is what is the most effective action taken to gain support of legislation? Is it A, letter writing, B, petitioning, C, in-person Zoom meetings, or D, phone calls? And feel free to go ahead and put those answers into the chat. Okay, looks like almost unanimous. The correct answer is C, in-person or Zoom meetings is the most effective action. Once we've located who our legislators are, the next step is to reach out to them to actually schedule a meeting. We would first suggest reaching out via email. If your legislator hasn't answered your email, feel free to send a follow-up email. If this is unsuccessful, an almost guaranteed way to really secure that visit is to give the office a call directly. Ideally, we would like to have our visits face-to-face. However, due to the COVID-19 pandemic, majority of these meetings over the past 2 years have been done virtually, and this has been successful. There are a few important points you want to include in your email to your legislator. You want to identify yourself as the constituent, again, because you're that voting member within their district, and that you're representing NYSCHP. Mention that you are a pharmacist, pharmacy student, pharmacy resident requesting to schedule a meeting. You can ask them whether or not they feel comfortable in an in-person meeting or if they would prefer a virtual meeting via Zoom or WebEx. Include the bills and the bill numbers of what we're actually advocating for. This helps the legislative office just to help them prepare for the visit. And in case they do have any questions they want to prepare beforehand. You also want to include the day and times that you're available to meet with them. Keep in mind, don't be discouraged if you're not getting an answer back. Send that follow-up email. Go ahead and call the office as well. These offices are extremely busy, and a lot of times you might not be meeting with the legislator themselves. You may be meeting with a staff member, for example, like the chief of staff. Here's an example of an email that Dr. Rachel Quinn sent over to her legislator. Let's read through this sample email. So as we can see, Rachel identified herself as a pharmacist and a constituent representing NYSCHP. She mentions our 3 bills that we're advocating for, our CDTM bill, our CLIA waive testing bill, white and brown bagging bill. And she includes the dates that she would be free for this meeting, Advocacy Week, which is February 14th through the 18th. And she also suggests that this meeting could take place in person or virtually, whichever they feel more comfortable with. There are also other sample emails that you can use, and they can be found at nyschp.org/advocacy. Once you've secured that visit, the next step is to prepare. You want to research your legislator. You want to know, does this legislator already co-sponsor or even sponsor one of my bills? If that's the case, you can go into your meeting starting with a thank you so much for your support. And this is the changes that we can project to see based on your support. Also, you want to know, what is their current committee status? As we spoke about earlier, a couple of our bills are in different standing committees. If you're meeting with a legislator who's part of one of those standing committees, whether that's Rules Committee or Higher Education Committee, educating them on these bills might help promote that bill be moved out of committee status and to the floor. You also may want to attend prep calls. As Rachel spoke about this week, we're having prep calls for Advocacy Week that you may sign up for. And the links, I believe, was put into the chat. But even outside of Advocacy Week, you can always reach out to seasoned grassroots members. Almost every NYSCHP chapter does have a grassroots advocacy committee, so you can reach out to one of the chairs if you don't feel comfortable. Before the meeting, you may also want to assign talking points to those attending that may relieve some of the stress on you if you are the constituent and a little bit nervous about the meeting. You also always want to be professional, be flexible, be on time. whether that's in person or virtual. The legislators do have a lot that they do throughout the day, attend many meetings, and you always want to show professionalism. And lastly, you want to bring bill information that you can leave behind. As we went over these bills, I know some of you may be thinking, wow, this is a lot. Well, that's what the legislator might be thinking as well. So using the sheets that are found on nyschp.org/advocacy, they're one sheet summaries of the bills, including the bill numbers, what exactly the objectives are for each bill, may be extremely helpful for the legislators. And these fact sheets are found at nyschp.org/advocacy. Now that you've prepared for your visit, it's time to discuss what is the actual meeting structure. Everyone attending the meeting should introduce themselves, whether that's their name, their title, where they work. The constituent should then identify themselves, and you can mention that you are representing NYSCHP. The next point I think is probably the most important. You really want to gauge your legislators' understanding of pharmacy. You'd be surprised at how many people don't know the scope of practice of pharmacists. You may want to explain, what is the schooling like? What is residency? What is fellowship? What are the different areas of pharmacy practice? And you can start out by saying, do you know any pharmacists? Which kind of relieves a lot of the stress as well if you're a little bit nervous for these meetings. You then want to review the bills and provide the bill numbers. What's important is to provide personal examples of how these bills affect patients and your constituents' community. I feel like having those impactful stories will make the legislator more likely to want to co-sponsor your bill. And if they ask you a question that you don't know the answer to, don't feel discouraged. Write down the question and tell them that you'll get back to them. At the end of the meeting, you want to thank your representative for meeting with you. And don't feel shy to ask for sponsorship or co-sponsorship for the bills. You also don't forget to take a picture. Always ask permission first to see if you're able to share that on one of our social media platforms. Lastly, the effectiveness of a meeting increases with good follow-up. You want to try to develop a relationship with your legislator. Send a thank you email to them, including the answers to the questions perhaps that they asked that you didn't know the answer to. You can also include the bill fact sheets that are found on the nyschp.org/advocacy website for their reference. And you can include the picture that you took during the visit. And even after this follow-up, feel free to send them multiple follow-ups throughout the year to really establish that relationship and keep providing them stories of how these bills and how pharmacists really impact patients in their community. I want to end with some advocacy misconceptions. There may be reasons you're thinking right now why you may not be able to advocate. The first one is something that I definitely felt when I started grassroots a few years ago. I don't feel confident talking to legislators. I'm afraid of public speaking. I don't know enough about these bills to have this conversation. But what's important to remember is, as I said, NYSCHP, every chapter has a grassroots advocacy committee. There's co-chairs, there's seasoned grassroots members who will attend these visits with you. You're never alone during these visits. If all you want to do is show up, set up the meeting, show up and say, I am the constituent, that's perfectly okay. And when you're ready to eventually lead a visit, that's great. But if that takes you 5, 6, 7 visits, that's also okay too. The next one is, I don't have time. Emailing or calling a legislative office is really quick, especially because there are sample emails that you can actually send to your legislator that is a NYSCHP resource that you can find on the website. And these meetings, because they're done virtually, it really takes out a lot of that travel time. And these visits can be done as quickly as 15 to 30 minutes. Next, another misconception is, I don't live in New York, therefore I don't have any constituents. Even if you don't live in New York, you can use your legislators from your work address. How do these bills affect patients in their neighborhood? This is something that your legislator wants to hear and wants to discuss. Lastly, this bill, this grassroots advocacy efforts, they don't make any difference. Although New York State is behind in pharmacy legislation, every visit can count. And this is something that Dr. Quinn alluded to earlier, as we were able to get our immunization bill passed and eventually signed by Governor Hochul this year. If you want to become more involved, this slide includes all the NYSCHP chapters within grassroots advocacy, their chairs, and their contact. Feel free to reach out to them if you're interested. And this is at any point, not even just for Advocacy Week. In conclusion, meeting with your legislators promotes expanded scope of practice for pharmacists. The goal of our CDTM bill is to add nurse practitioners as collaborators and remove the sunset, as this bill is set to sunset again in July of 2022. The goal of our CLIA bill is to add pharmacists to the list of licensed healthcare professionals who are qualified to perform these non-invasive clinical laboratory tests. And lastly, the goal of our white and brown bagging bill is to completely prohibit brown bagging and add restrictions to white bagging. The Grassroots Advocacy Committee will help build your legislative confidence, and the first step is to locate who your legislators are. And you can use these links on the slide to figure out who your senator and who your assembly member is. And we truly hope you decide to get involved. Thank you for listening. And with that, we'll take any questions from the audience.
Well, thank you, Dr. Payo and Dr. Quinn, for that presentation. I do have one question, and I want to get your thoughts on it. Do you feel it would be helpful to get other healthcare professionals involved in advocating for us, maybe the doctors we work with? And if so, what's a good way for them to get involved?
I can start first. So I do think it would be extremely helpful, especially in regards to the CDTM bill. Under the CDTM bill, we can only work with MDs or DOs. So I think I think if they could attend advocacy visits with us, it would demonstrate their support for furthering the expansion of the bill. I do understand that they have very busy schedules, so if they can't attend visits with us, they can always write letters of support for the CDTM bill that we can share with our local legislators. And just for example, at my current place of employment, many of the medical doctors or doctors of osteopathy, once they learned about the limitations placed on CDTM pharmacists, wanted to know more about this bill and wanted to know why there were so many limitations, especially regarding the collaboration with nurse practitioners. So I believe if we did have their support, either in writing or at visits, we would be able to potentially remove the sunset on this bill and add nurse practitioners as the providers of service.
And I agree with what Rachel's saying. I think having our providers and even our mid-level practitioners, advanced care practitioners attending some of these meetings to really discuss the impact that we have on patient care. I think it's kind of unfortunate that we have, some of these societies who are making statements pretty much, trying to put restrictions on what pharmacists can do. But if we think about all of us who work in CDTM, the physicians and providers that we work with, really truly appreciate all the work that we're doing and the impact that we make on patients. It's present, it's been shown. We have data to support it. So I think that having them attend the meetings and even writing letters, I know that's not the most effective way of gaining support, but having them attend the meetings and really push for us, I think would really make a difference.
And then I have a question in the chat. Will CDTM be available to community pharmacies?
So unfortunately, in New York State, CDTM is restricted to Article 28 facilities. So facilities that are regulated under Article 28 include diagnostic centers, treatment centers, or hospital-based outpatient departments, which includes outpatient clinics. But unless it is an Article 28 facility, that is currently one of the restrictions we have on CDTM.
Okay, excellent. And another question in the chat is, who else is qualified for CLIA wave testing besides pharmacists?
I'm sorry, can you repeat that question, Dr. Gerber?
Yes, who else is qualified for CLIA waived testing?
The bill for us, especially with CLIA wave testing, is specific just to pharmacies. I know CLIA wave testing can be done in physicians' offices. I'm not sure if that answers the question.
Okay, and then I guess one last question for me. I know we have a lot of people on this call that are very heavy in academia or work in an academic institution. And what's a great way for students to get involved?
I can start. So I think by having students attending a lot of these visits, because they are the future of pharmacy, having them attending these visits, even having pharmacy advocacy put inside the curriculum for pharmacy schooling, I think would really start to introduce how much we need to do in New York State in order to promote our profession. I think it starts in the classroom once, next to our pharmacokinetic class, they should have a pharmacy advocacy class, for example, and start to push our profession forward.
I agree, and I think we've seen a large increase in student involvement, especially during Advocacy Week based on co-curricular credit. So that's something I'm excited to continue seeing with schools of pharmacy. After all, one day they are going to be pharmacists, and if we're not advocating for our own profession, who will?
Excellent. Thank you for all those answers. Does anyone else have any questions for our two panelists? Okay, excellent. So I guess then we will conclude with today's webinar. I want to thank Dr. Samantha Paone and Dr. Rachel Quinn for an amazing job today. Very informative presentation. You should be receiving an email from NYSCHP in approximately 1 week with the links that are necessary to obtain the CE.